Thank you everyone for a wonderful session. Moving on to the next lecture, Dr. Santok Singh Anand Endowment Lecture. I would like to welcome Dr. Srivastava KN from New Delhi, Dr. Dribachuri Bhaumik from Kolkata, Dr. Anand Kumar Mishra from Lucknow, Dr. Kanakavil M from Chennai, Dr. Karthikeyan C from Trivandrum, and Dr. Ramanuj Mukherjee from Kolkata. Welcome all of you.
Hello.
Manoj, are you ready?
Yes, sir. Sir, good afternoon, everyone. Good afternoon,
Good
chairperson.
afternoon, everyone.
Ready, sir.
With the permission of the co-chair, can I request the senior most person, Dr. Srivastava? I think Dr. Srivastava, are you with us?
Yes, sir. Sir, sir needs to
Sir,
have the
please,
phone
can you,
muted, I think. Unmute.
You are okay, sir? You are connected well? I think he has some challenges. With the permission of my co-chairpersons, Dr. Brahma sir, Dr. Karthikeyan sir, can I introduce the oration now, sir?
Yeah, I think I was supposed to speak
Please
about
go
the
ahead, sir.
Dr.
Please go ahead, sir. Please go ahead.
Dr. Santok Singh Anand. Can I have the slides?
Absolutely, sir. Please.
Can I have the slides? Dr. Kanagwal, can you hear me?
Very well, sir. You want me to show the slide of Professor Santok Singh, sir?
Yeah, this is what I was told, that slides will be
I will
on.
do it in a moment, sir. I thought you are going to have. I will show in a moment, sir.
Yeah, sure.
Can I show now?
Yeah, please do.
Yes, sir.
In fact, at 6, I have a panel discussion in Hall E.
No problem, sir. This is about Professor Santok Singh.
Yeah, I can now start.
You can quickly read.
Should I? So, good evening, everybody. Dr. Kanagwal, are you with me?
Yes, sir.
Yes, sir.
Yeah.
Yes, sir.
So, I'll just now, this is my privilege to introduce Dr. Santok Singh Anand, in whose memory we are having this lecture today. Dr. Santok Singh Anand was born on 9th November 1909 at CB in Baluchistan, in the present Pakistan. He graduated in medicine in 1932 and took fellowship of the Royal College of Surgeons of England in 1939. He was honored with FACS 1951, FCCP 1951, and FAMS 1960. From 1943 to 1947, he worked as Assistant Professor of Surgery at King Edward Medical College, Lahore, Pakistan. Department of Medical College, Amritsar, from 1947 to 1962. He also had the administrative responsibility as principal of the college from 1958 to 1962. Dr. Santok Singh Anand was invited to the Postgraduate Institute of Medical Sciences at Chandigarh in 1962 on its inception, where he worked as director and professor of surgery till 1969. After his retirement from PGI, Dr. Anand became the advisor and secretary medical education for Government of Jammu and Kashmir from 1972 to 1975. Dr. Anand was the Hunterian Professor of Royal College of Surgeons of England in 1956, Rockefeller Fellow in 1961, Visiting Professor to Royal Postgraduate Medical School, Hammersmith in 1967, Honorary Consulting Surgeon to Armed Forces of India since 1968, and Honorary Surgeon to many Presidents of India. Dr. Anand was member of Medical Council of India, Chairman Board of Surgery of Indian Academy of Medical Sciences, member ICMR, and President of Selection Board of Union Public Service Commission. The fragrance of his teaching, the moral guidelines laid down by the great man of yesteryears, and his personality still pervade the atmosphere and shall continue to do so as long as students are around. Great teachers leave this world and ascend to those immortal mansions above, whence all goodness emanates. They live always in the hearts and in the minds of those they taught, wrote a student of Dr. Anand. Dr. S.S. Anand was President of Association of Surgeons of India in 1958. He passed away on 4th June 1996. Endowment lecture was started by ASI in 2009 in the revered memory of Dr. Santok Singh Anand, one of the foremost doyens of surgery in India, from Medical College, Amritsar, and PGI, Chandigarh. Now, today, Dr. Santok Singh Anand Endowment lecture is being delivered by Dr. Ramanujam, and I'll request Dr. Kanagwal to ask someone to introduce Dr. Ramanujan. Dr. Kanagwal, please. I will not be hear you.
Dr. Kanagwal, would you please unmute?
Please unmute.
Dr. Kanagwal, you'll have to unmute.
Thank you, Professor Srivastava, sir. Thank you for reading out the citation for this oration. And in fact, it is quite inspiring that ASI has appropriately recognized the great man and the past president of National ASI and his national and international contributions to be well known, and an oration is instituted. May I now request the co-chairperson to introduce Professor Ramanuj Kar. Over to you, sir.
Thank you, Dr. Kanagwal. It's my privilege to introduce today's speaker, Dr. Ramanuj Mukherjee, who happens to be essentially my younger brother. And born in 1977, Dr. Ramanuj Mukherjee is a medical graduate and a surgical postgraduate of the Calcutta Medical College at Kolkata. Obtaining his master's in general surgery in 2005, he followed this by clearing his national board's DNB and membership of the Royal College of Surgeons, MRCS, of England in 2006. Throughout his educational years, Dr. Ramanuj has been in the forefront of excellence with many distinctions, top spots, and gold medals. He also has the fellowship in minimal access surgery. His surgical work experience has been obtained by senior registrarship at AIIMS New Delhi, at the IPGMER Kolkata, and the ASICON Medical College in Kolkata. Currently, he is an associate professor in surgery at the Purulia Government Medical College in West Bengal. Very few, I must say, are blessed to see the scientific mind, industry of effort, and passion for teaching all bundled together into one individual. Dr. Ramanuj Mukherjee is one such surgeon. His contributions and exchange of knowledge with mentoring and sharing of surgical skills is vast and needs to be applauded. Almost all surgical organizations have used his rich abilities at such activity to further their programs and events, from basic surgical skills to advanced laparoscopic skills, and now he is on the panel to train the trainers or taught to. To add to all this is his prolific production of papers and publications into index journals, and has an ongoing conduct of several research and clinical trials. His pet emphasis has always been, though, safe surgery, quote unquote. All the academic inputs has now culminated with Dr. Ramanuj becoming a very popular and entertaining surgical quiz master at surgical meets across the country. He has been instrumental in making the National Surgical Quiz for surgical postgraduates a signature event at the yearly ASICONs for the last 5 years. The Association of Surgeons of India is honored, proud, and privileged to invite the young and talented Dr. Ramanuj Mukherjee to deliver the Santok Singh Anand Award Lecture for 2020 on his chosen topic of Implementing Surgical Safety Checklist 2009 to 2019, the 10-year challenge. Thank you.
Well, thank you, Chairperson, for the kind
Thank
words.
you, Professor Bomi.
Thank you.
Thank you.
Pardon?
Right. Well, thank you, Chairpersons, for this. Am I audible? Hello.
Very
Yes.
well.
Okay. Thank you. To the audio visual, I think I have 20 minutes. So can you kindly reset it to 20? Thank you, sir. Sir, I think that thank you for the kind words, and thank you, Dhruvada, for again the kind words. Thank you. With this, I think I will start. Ladies and gentlemen, to a topic that is very close to my heart. But before that, on a cold wintry evening on the 2nd of December 1984, this picture is of a Bhopal gas tragedy where, due to one single valve which killed multiple people. February 1, 2003, one human error in documentation of a thermal sensor again erased Colombia. This picture talks off on the left-hand side of a very famous actress of Bollywood, Sridevi. On the right side, you have her mother, who was diagnosed with a brain tumor. She took her mother to the best surgeons in the world, so-called best surgeons in the world, in Memorial Sloan to have the operation done, where, due to the CT scan plate being switched in a reversed, the opposite normal lobe of the brain was removed instead of the diseased one. Now, ladies and gentlemen, if you are thinking, wow, man, these bad things do happen. Well, interestingly enough, the love story of surgery is not exactly what of India, the academic for 20 last decade from 2009 to 2019, this has the 10-year challenge is that am I okay, ladies and gentlemen? No. So in this class, the you an account of what exactly safe surgery is and how my evolution into this had come around. Now, to talk about the audit data, so when I look back in time, it was again a month of December, where in that month, well, due to the conferences, we do a less. We had a re-exploration of an open cholecystectomy patient, and that lady had now, as you know, the hemangiomas which bleed like hell will the anesthesiologist was shouting at us, bring blood, and everyone and asked, and we had a shudder down our spine. Packed the liver, the patient survived. Wrong. The patient survived, patient went home. Not know what. Then the next question is, whose fault was the preoperative? Was, I do not know, again bad luck. After the operation, in which there was more of sweat and adrenaline, I had the opportunity had in that coffee break room to talk to one of my thoracic surgeon colleagues who told me an incident of a 3-year-old young girl in Switzerland, and that young girl had had a fall in an ice lake, immediately went into an cardiac arrest, was shifted to a local hospital, which was very small. Believe me, it was not a university big hospital. And in that small hospital, that 3-year-old child was intubated, put on a ventilator, and then for the next around 1 week year episode of an interview. What was interesting is that the patient survived, but everyone asked the team survive a small checklist. The checklist was during the oxygen connection sore. And that is the way a small distance into next day. So with this, ladies and gentlemen, people started thinking about any do occur with patients, and believe me that immediately massive in surgical safety. It was an outcomes. So talk about the lingo. And after that tea break and my consultation with the thoracic surgeon, that can happen. And in important, the most important thing is that whom should we blame? Then people started understanding that there is a philosophy that needs to be corrected. That means it is basically like one is going to happen. So the only thing that can change is this. And while wrong side surgery, ladies and gentlemen, and those things made me really think over and horrified. So then the next question was that how could we change over? The more I read, the more was something that the same year, 2009, the World Health Organization brought out a guideline. And the more you have read the guidelines, believe me, ladies and gentlemen, they are one among those which change your life. It has changed mine. It will do yours. Is a very single sheet of paper called as a surgical safety chart. Now, the question that you are going to ask me is that at the beginning, who is maintaining this chart? The answer is the team maintains the chart. It is not the job of the sister, it is the job of the team to maintain. While we communicate during that, the safety chart has taught us to mark our sides and be safe. But the most important thing that those who are critics are going to ask you, Ramanuj, who told you that the safety chart is something that we know, but how do you know that it works? The answer is that there are no umpteen evidences to know they are working. The best example from this one is this area to show. In this clutter, there is only one thing. There is a statistically significant death reduction. There is a statistically significant reduction in complications as well as the whole spectrum. This study was done as a part of a multi-center study in India. I work as a part with the government of West Bengal to implement the surgical safety. And what we do is that when we teach, these are our part of the training slide, we start by something called as briefing to teach. And after the briefing is done in the preoperative lounge, we begin by something called as a sign-in. So those of you who have not seen one, which is very rare, every hospital in India more or less will follow this. Remember, is done by the stable nurse. Timeout is something that is attended by both anesthesia surgeon and the nurse, and again is done by the nurse. So that means it is empowering your nurses to do that. Now, the most important concept is that before you give the incision on the skin, please do something called as a timeout. During the operation, you have communicated, but what is very important is, till today, you talked about sister, give, take, count. Tomorrow, please talk over, sister, I want to do a sign out. And these are multiple options that we have. So please remember that there are three terms that I used. Number one, sign in. Number two, time out. Number three is sign out. Now, at the end, the things did go well and did not. Please go for a debrief. So there are 5 steps of this. Now I come to what is my experience, because you will be asking, we knew everything, Ramanuj. So what is that great thing in that? Well, ladies and gentlemen, as I've told, the last 10 years, and these are all the ICMR sponsored projects, and we had an university thesis with one of our residents working on this. If you see the graph over from 2009 to 2019, interestingly enough, the 2019, the government of West Bengal came up with an compulsory amendment of using the surgical safety chart for every operation. And for that reason, maybe the incidence of or the usage of this increased. What was important is that, but for the last from 9 and 2010 till 2017, we worked with the Department of Safety and Aviation from the IIT, and then we consulted with them of mechanical safety, and they said that, okay, doc, divide all of your steps of that surgical safety checklist, which had 19 items. We did split it more and made it 22, and then we divided it into questions. Now, we made a form on our own based on that one. And the more we made a form, we talked with our statistical and engineering colleagues. And as you can see with this cursor, we made into something called as a variants. 4 was given when the patient had gone with maximum identification that could be done, or the maximum compliance, you may say. 0 was for nothing that was done. If you're thinking, well, it's a simple one, what is interesting is now see what happens when we do implement it in a real world. In an average score, out of all these questions, you see some are implemented, but none of them in a patient cohort of 130 never touched 4 or 5. This is what is very interesting in this group. Now what we did was we tried to see inter-unit variation because there may be practices that change. Then we compared about what happens before sign in, time out, sign out, and then we calculated something called as a grand average to identify. What is interesting is that more or less all the units, as you can see, did not have any statistically different in their safety protocols. They were more or less safe, but definitely should have been little more safer if you have followed this. So what I did was that rather than showing you the whole big cake and the pizza, my lucky number, okay, is the 10, and I really like football. I focused on the 10th, which was a preoperative antibiotic prophylaxis, which is something that every surgeon does. And I varied from 0 to 4 in this group. Now, if you see the variation from 0 to 4, the first blunt question that we asked in this year was yes and no. The answer was no with 23%. We did an briefing to the team. Next year, we tried to follow it. Well, again, it doesn't change that great. Then he went on for a particular source identification. What was the problem? And then it came down to 9.6, still not 0. Now, who administered this? That is something that changed the game, ladies and gentlemen. As you see in this one, we identified that it was the anesthesiologist. That means you need to talk with your anesthesia gentleman. Was it repeated? Again, as you can see, the changes that are happening over time. Now, as you see, if this graph suggests that this is the 2017 timeline, we have had a sharp decrease in not done versus less than 4 hours of the incision. So by 2017, we could now more or less change the graph from not done to being given less than 4 hours after the incision. Now we calculated that if this part is the point where incision was given, when was the time antibiotic was repeated? Because I talk about antibiotic prophylaxis because this is something that every operation or surgeon does. So this is the timing of administration that we saw. As you can see, this green colored thing is 2017, and the more we go by, more or the less we have a good compliance. Greater than 60 is in 2015, which had really decreased, and this product increased into this. Now, why was it missed? We are asking introspections. The reason for asking now is that now see, people delegated the job from 67% till 52%, forgot to give cost factors and others were not important, but delegation of the duty came down in the 2017. That means more the evolution came with the practice and the practice and the practice of this. So that means the only intervention that we had to take is we had to have over a cup of tea or coffee, talk with the team that, okay, doc, see, this is the thing that we are doing. You are missing that on that point. Everyone took it in a good spirit, particularly the seniors, and they told that, okay, Doc Mukherjee, we did that. Now, what is important is that, so who told you that this thing works? What is important is that is there any evidence of a surgical site infection and does it help? The answer is yes, it does. If you see again dramatically, again in a class 4 wound, we decreased down to 20, which was an acceptable data. Now, if you look closely at again the full data set, see that surgical sites not being marked in 2009 were a dictum. We did not mark which sided hernia. In 2019, we had really achieved that amount, that but still not a 0. Antibiotic prophylaxis forgotten was this grade, which was again a bit steeper, but again by 2019, more or less, we had come down to an acceptable level. If you think compliance, this dark thing is 2009. Probably the consent issues and this the consent issue and the surgical site markings were the best one that were done. We are now in the process of developing an application. This is on an Excel platform where we are now calculating the safety scores. If it is less than 80, we say, docs, do not do the operation now, do this. Well, I was working now, I'm posted as a professor of surgery in ASICON Medical College. Before that, I used to work in a peripheral hospital in Purulia, which is a part of the peripheries of Bengal. We modified that, and believe me, ladies and gentlemen, till to this date, even today morning, the gentleman at the theater told me, okay, sir, we are still maintaining that honestly and meticulously, and we are a little modification in which we added the surgeon's designation and the post and his signature. Now the question that comes, ladies and gentlemen, to you is, why should you be doing this? After all this thing, you should be asking me, Ramanuj, what is the use of doing all of this? The second important reason is that please talk to a lawyer, and in these days, the important issue that has come is maintaining this chart, because the court of the law will require you to see if you have left any sponge or mop. If you have not maintained the chart, please remember things are really not nice. Now, the things that you can change is that if you want an outcome, your hernia patient is going home without an infection, gallbladder going home with a correct surgery, a hernia on the right side getting operated for a right side, remember the change has to come in you. This is a very simple change, is to implement this one. That's it, ladies and gentlemen. No more rocket science. This is so simple as that. If you can think about beginning like the last year and the year ago, what we did was that we had an epidemic of an infection. You can see what was interesting is that in this time on the Tuesday OT, we had much acceptable rates, where on the Saturday OT, we had much less. The only point that we recognized was that on the Saturday OT, we had our interns who were scrubbing in, and then we identified that they were the weak link. And if we could teach them to have and proper hand washing, which again majority of interns took the third attempt to teach, the 4 even took a 6th attempt, and this time we maintained a checklist that whether they are washing their hands or not. With this, we had a publication this year in the Indian Journal of Surgery, Achieving and Perfect Hand Washing. You can see it took many attempts to see, but at the end, we could now have the pre-epidemic of hand infection, you may say, or wound infection into that rate. So ladies and gentlemen, this is something called as an internal audit and an audit cycle to improve. I'm coming to the end, ladies and gentlemen. The last 10 years, we have started a journey. Definitely, we have not ended the journey, because still briefing and debrief are still not done routinely. We are still in the process of development. Probably the next decade, 10 years down, when I will be presenting more of our data, we will be doing that. So this is the last slide. I do not know how many of you have seen the movie. This is about Captain Scully. With the name by that.
Time is over.
Yeah, ma'am, this is the last slide, and I have ended now. What happened was that after the flight took off, the flight got hit by the bird, and now the pilot had to take a call to land it to another airport, which was about 10 minutes away, but his fuel and he did not allow. Now, ladies and gentlemen, not everything is in a checklist. Not everything goes by the book. What comes is something called as a common sense of the sense of safety. So the pilot decided that the best option would have been to get into the Hudson River. Okay, that's the point where Captain Scully decided that it is better to land at the Hudson River than this. So with this, ladies and gentlemen, I will finish my talk, the Santok Singh Endowment lecture. For everyone who is listening to this and wishes to change the practice for the next decade, believe me, this is a very simple manual, freely downloadable from the internet, from the WHO site. Please go through this small manual. It can be implemented even from the smallest of the small to the largest of hospitals. If you need an year-ending read, I'm a fan of Mr. Gawande, Dr. Gawande, and is one among the prolific writers. With this, thank you everyone, particularly the Academic Council, the President and the Secretary ASI, for the Santok Singh Anand Endowment Lecture 2020. Thank you everyone.
Thank you, Professor Ramanuj, for such giving a brilliant exposition of the surgical safety. As we are running out of time, can I request Dr. Karthikeyan sir to give a 1 minute quick comment, please?
Sir, please wind
Okay.
up because a lot of things are pending. Otherwise,
I agree, sir.
Yeah,
thank you so much. Thank you, Dr. Ramanuj sir. Thank you to my chairpersons for allowing me to moderate this session. Thank you, Santosh sir. Thank you, the ASI, for giving us the opportunity. Thank you, one and all.
Thank you, sir.
Thank you.